Blood smells like copper and old pennies, but wound care smells like something older. The mineral sweetness of healing that has been working too long without adequate help. And beneath it, silver sulfadiazine. And beneath that, the early metabolic signature of tissue, deciding which way to go. I know that smell the way I know the Hindu Kush at 10,000 feet, and the cordite note of a cleared room. They called me the cautionary tale, the demotion desk, the nurse who forgot her place. I had been in the wound care clinic for 4 months when the special forces came, and the only name they were looking for was one nobody at Sandia Regional had ever heard. Let me tell you what happened when they found her. My name is Junie Reese. I am 45 years old. I keep my watch on my right wrist. I have kept it there for 11 years, since a team sergeant in the 5th Special Forces Group told me it was the only way to read the time without losing your dominant hand, and I had listened, and I had never switched it back, and nobody at this hospital had ever noticed, which is its own kind of story. I had been at Sandia Regional in Albuquerque, New Mexico, for 2 years, working surgical nursing, and then I had testified in a patient complaint hearing about a surgeon whose documentation did not match his outcomes, and 2 weeks later I had been reassigned to the wound care clinic on the 2nd floor, which is a real department staffed by real nurses, doing real work that happens to be the least visible floor in the building. Sandia Regional smelled of the wound care clinic, and the cafeteria 2 floors below it, and the specific warm plastic note of a building that has been running its vac system at the wrong setting for a decade. The clinic itself was 12 rooms off a central corridor. Bright in the way wound care has to be bright, overhead exam lamps, no ambient shadows, everything visible and accessible. The linoleum was clean. The supply cart was stocked the way I had stocked it, which was differently from how it had been stocked before I arrived, because the person before me had not worked in environments where the difference between having the right tool in position 1 versus position 4 was a man's leg. I had rearranged the cart in my first week, and nobody had said anything, because nobody paid enough attention to the wound care clinic to notice. To the rest of the hospital, the wound care clinic was where things went after the drama was over. To me, it was the most exacting metric of whether the drama had been handled correctly in the first place. A wound does not lie. It tells you exactly what was done and what was not done, and what the body has been trying to compensate for in the interval between. I had learned to read wounds in 3 languages: clinical, tactical, and the third one that has no name, which is the language of tissue that has been doing its best in the absence of adequate care. I read that language every day. The clinic was not a demotion. It was a different kind of work. I had decided to treat it that way. I keep the exits cataloged without deciding to. 2nd floor, so the stairwells are close. Fire exit at the east end of the corridor, alarmed. Service elevator, south face, not alarmed after hours if you use the maintenance key, which I had noted from the facility's schedule posted inside the supply closet. Main elevator bank, center. The clinic's window faced west, toward the Sandia Mountains, and at 7 in the morning the light came through it at an angle that made the room feel briefly like somewhere else. Somewhere with altitude and cold air, and the specific quality of morning I had known in other mountains, in other years. Dr. Hessel had not been in those mountains. Dr. Hessel worked the wound care attending rotation on Tuesdays and Thursdays, was 29 years old, had done her residency at a very good program, and had approximately 18 months of supervised wound assessment experience. She deferred to me on every case and pretended not to know it, which was an arrangement I had decided was workable. The coffee mug on the break room counter was not mine. It had appeared 2 weeks after I arrived, placed there by a day shift nurse named Corey, who had made a wager with 3 colleagues that the demoted surgical nurse would quit before her 4-month mark. The mug had collected $12. My 4-month mark was this Friday. The mug sat on the counter every morning when I came in, which told me that nobody had won the bet yet and that nobody was ready to concede it. I looked at it every morning the way you look at something that is trying to tell you something you already know. I went to work. Philip Weston, the hospital's chief operating officer, had arrived at the clinic on a Monday 3 weeks ago, with the bearing of a man performing an administrative function he considered beneath him and intending to complete it efficiently. He was 55, silver-suited, the kind of physically fit that comes from a gym membership rather than from carrying things over long distances, and he had the specific cologne of a man who has confused the smell of authority with the fact of it. He had asked me to remain after the department all-hands meeting that morning, and I had remained, and he had addressed the assembled 22 staff members of the wound care clinic in a voice that was not loud but that was calibrated to carry. "Nurse Reese is an example," he said, "of what happens when clinical staff mistake advocacy for authority. She is also an example of the kind of correction that keeps this institution functioning within appropriate hierarchies." He looked at me, not unkindly, which was the part I found most interesting. "A cautionary tale," he said. "That is the useful function of this assignment. 22 people in the room. I had counted them when I walked in. I counted them again now, the way you count when you want a number to focus on instead of a face." I looked at the wall behind Weston's left shoulder. "Understood," I said. I thought about Kunar Province for the approximate 3 seconds it takes to think about Kunar Province and then file it. I thought about Staff Sergeant Benedict Lowe, who had taken a round through the right calf in an alley in Asadabad, and whose compartment pressure I had measured at 41 millimeters of mercury, and whose leg was alive because of 11 specific minutes in 2016 that I had not thought about in a long time and was not going to think about now. I went back to work. The veteran in room 6 was named Dolores Carver. She was 63 years old, Army, a nurse herself. She wore the Army Nurse Corps pin on the collar of her hospital gown, the way certain people wear things they have earned, with the specific casualness of someone who has stopped needing to prove the earning. She was in for a chronic venous ulcer on her left lower leg that had been inadequately managed for 8 months, before someone at the VA had written a referral that eventually landed her at Sandia Regional's wound care clinic, and I had been cleaning and redressing it for 3 weeks, and it was improving, which was not complicated once you understood why the previous management had been insufficient. She watched my hands when I worked, not intrusively, the way a person watches someone doing something they also know how to do. 18D, she said the 3rd week, while I was applying the compression bandaging. I looked at her. "Special Forces medic," she said. "The way you debride, you go to the healthy margin first, work inward. That's not nursing school." "It's one approach," I said. "My son is 18 series," she said. "He showed me the manual once." She was quiet for a moment. "You don't have to tell me anything." I applied the final layer of the bandage and smoothed the tape down at the edges with the flat of my thumb the way I always do, because the edge is where compression failures start. "How is your pain today?" I said. 3, she said, which is a lie, but manageable. I documented it as a 4, which was what her face said, and which was the more clinically useful number. She did not ask me anything else that visit. She watched me clean the cart afterward with the particular quiet of someone who has already decided what they think and doesn't need confirmation. That had been last week. This morning, the mug was still on the counter. $12 uncollected. 2 days until Friday. I went to work. I felt it in the soles of my feet at 10:47. which is how I feel things that arrive by rotor, because I have spent enough time on flight lines to know that rotors transmit through asphalt and concrete and building materials at a frequency that the inner ear reads before the brain does. One aircraft. Then a second, lower and heavier, the specific signature of a A-72 Lakota, the light utility helicopter used by special operations for low-profile transport, carrying full manifest weight. I was in the supply room when the vibration arrived, and then I had identified the aircraft type and weight class and landing pattern by the quality of sound through the building's frame before I was conscious of doing it. 2 aircraft. Kirtland Air Force Base was 4 miles southeast. My hands went into my pockets. Not here, not this, not my problem anymore. The sound of tires on the parking structure ramp. Multiple vehicles. The specific diesel note of F-250s running hard. I counted 3 by sound, spaced 30 seconds apart, convoy spacing. I walked to the supply room door. I did not open it. I stood at it. In the corridor outside, I could hear the clinic beginning to respond to something. The specific frequency shift that happens in a department when information is arriving faster than the framework for processing it. Doctor, a sales voice, uncertain, from the nursing station. Corey's voice, sharper, and beneath both of them, a sound I had not heard in 4 years, which was the specific flat affect of a man who has delivered bad news in bad places and has learned to deliver it without inflection, because inflection is a luxury for people who have time. "We need wound care," the man said. "Now." Both of them. I opened the supply room door. There were 4 of them in the corridor, in civilian clothes that did not match the haircuts or the posture or the specific economy of men who have learned to be efficient in their movements, because inefficiency has consequences. Behind them, 2 men on gurneys pushed by 2 more. 8 total. I counted them before I was aware I was counting. The man at the front was Master Sergeant Del Reyes, 5th Special Forces Group, whom I had last seen at a forward operating base in the Paktia province, at an elevation that made everyone's nose bleed for the first 3 days. He was 41 now. He looked at the clinic corridor with the assessment of someone cataloging a new environment, and then his eyes found me, and the cataloging stopped. Weston had arrived from the elevator. He had been doing his Tuesday administration rounds on 3 and had apparently been intercepted by the nursing supervisor and redirected here, because he was wearing the expression of a man who has been told something he does not yet have a framework for. "What is the nature of this visit?" Weston said. "All patients require admission through, sir," Reyes said. "We didn't come here for you." Weston opened his mouth. Reyes looked at me. The corridor was quiet, the way corridors are not usually quiet. Doctor, a cell had stopped moving. Corey was at the station, pen suspended above a clipboard. 2 wound care nurses had arrived from rooms 4 and 7 and stood at the corridor junction with the specific stillness of people who can feel that the weight distribution of a situation has changed without knowing why. "The legend," Reyes said. Not a question. Not loud. 2 words that he placed in the room the way you place something you have been carrying a long time and have finally arrived at the correct destination. Nobody in that corridor knew what it meant. Nobody except the woman standing in the supply room doorway with her watch on her right wrist and her hands still in her pockets. I was the only person who did not look around. I looked at Reyes. He had already found me. He had found me by the stillness, which is how he had found me the first time, too, in a doorway in Paktia, when he had said, "You're the 18D from 3rd Group," with the same quality of already knowing. I took my hands out of my pockets. And then I walked toward him. My posture was doing something I had not directed it to do. which was to stop performing the dimensions of a wound care nurse assigned as a cautionary tale. "What do you have?" I said. He told me, Specialist First Class Aaron Cortez, 24, right leg, blast fragmentation, soft tissue damage, and a lower leg compartment pressure that the team medic had measured at 38 millimeters of mercury using a Stryker device 40 minutes ago, and that was almost certainly higher now. Specialist Danny Oates, 22, left arm, traumatic open fracture, radius and ulna, wound contaminated, partial degloving, in need of irrigation and stabilization before the orthopedic surgeon could close. 2 injuries, 2 different knowledge sets. The trauma team in the main ER had both patients triaged for the or without addressing the compartment pressure first, which was the wrong sequence and would cost Cortez the leg if it stood. I looked at Reyes. "Cortez goes first," I said. "The fracture waits 20 minutes. If Cortez's compartment pressure is at 38 and climbing, he has maybe 30 minutes before the muscle dies." "The trauma attending wants to take them in presentation order," Reyes said. "The trauma attending is wrong," I said. I turned to Dr. Assel. "I need a Stryker compartment pressure monitor, a number 10 blade, and a fasciotomy tray. Bay 1. I looked at Corey. "Get Dr. Park from orthopedics on the phone. Tell him we have a degloving on the secondary patient that needs his eyes before he goes to the OR." I looked back at Reyes. "Which bay did they put him in?" "Trauma 1, he said. "Then, that's where I'm going," I said. Weston stepped into my path. "Nurse Reese," he said, "you are assigned to the wound care clinic. You do not have privileges in the trauma bay." I looked at him for a moment. "Mr. Weston," I said, in a voice that I had not used in 4 years, and that had not forgotten how to be itself. Not loud, not theatrical, just the specific temperature of a person who has made irreversible decisions in irreversible situations and is making one now. "Step aside." He stepped aside. I noted it was faster than I expected. I went to Trauma Bay 1. Cortez was conscious, which mattered. It meant the compartment pressure had not yet crossed into neurovascular compromise, which meant the window was real, and I was inside it. His right lower leg was tense in the specific way of a compartment under pressure, the skin taut and pale, the pain disproportionate to the visible injury. I confirmed the pressure with the Stryker monitor in 90 seconds. 41 millimeters of mercury. Every minute that number climbed, more muscle died. The trauma attending, Dr. Garza, was at the bay threshold. She had been briefed by someone in the 43 seconds between my leaving the clinic corridor and arriving here, because she was wearing the expression of a physician who has been handed a situation with competing recommendations and is deciding which one to follow. "The compartment pressure?" she said. 41, I said. "It was 38:40 5 minutes ago. The slope means we have maybe 20 minutes before irreversible ischemia. We do the fasciotomy now, before the OR. Lateral and medial release, both compartments." "You've done this before," she said. It was not quite a question. 11 times, I said. The last time, the pressure was 47, and we had no general anesthesia. We managed. I looked at Cortez. This will be simpler. She made her decision in 2 seconds, which was the right amount of time for it. "Walk me through it," she said. I gloved. I took the number 10 scalpel from the tray. I found the fibular shaft by palpation, the lateral release landmark, and I made the longitudinal incision along the lateral compartment, 8 centimeters through skin and subcutaneous tissue. And then the fasciotomy scissors through the fascia itself, and then the specific release of pressure that I have felt 11 times, and that is always the same. Not dramatic, not violent, just the quiet give of a structure that has been containing something and is finally allowed to stop. The leg's color began to change. And then pink returned to the distal foot in the specific way of blood, remembering where it was going. Medial release, I said, and moved to position. And then the second incision along the posterior tibial margin, the correct medial landmark, not the anterior, which is the error that produces inadequate decompression. And then the second fasciotomy, and the second release, and I packed both wounds and covered them, and straightened and looked at the monitor. 23 millimeters of mercury. Cortez looked at me. His color was different. His face was the face of someone whose body has just been given back a resource it was running out of. "You good?" I said. "Yeah," he said. "Yeah, I'm good." Reyes was in the bay doorway. He had watched the entire procedure without speaking, which is what Special Forces medics do when someone who knows what they are doing is doing it. They watch. They learn. They stay out of the way. He looked at the monitor reading. He looked at me. "Same hands," he said. It was not for anyone else, just the two of us. I peeled the gloves off. I went to find Oates. The orthopedic surgeon handled the fracture. I irrigated and stabilized the wound before he arrived, which reduced his debridement time by 20 minutes and improved the outcome in ways that would not appear in any documentation with my name on it. Oates would keep the arm. Cortez would keep the leg. These were the facts of the morning. I was back in the wound care clinic corridor at 12:40 when Reyes found me. Weston was there too. He had been waiting, I understood, for the moment when he could reassert something, although what exactly was unclear given the architecture of the last 2 hours. "I'd like to understand," Weston said, "on what basis a wound care nurse performed a fasciotomy in my trauma bay." Reyes looked at him with the specific quality of attention of a man who has assessed a situation and found it less complex than advertised. "On the basis," Reyes said, "of Master Sergeant First Class Juniper Reese, 5th Special Forces Group, 3rd OTA, 2010 to 2021. 11 years. 5 combat deployments, Afghanistan, Iraq, Syria, Mali, and one I'm not going to tell you about." He was not reading from anything. He had it the way you have the things you do not need to look up. Combat Action Badge. Bronze Star with Valor. For actions in Kunar Province, 2015, in which Sergeant Reese performed emergency surgery on 4 personnel under direct fire with no anesthesia support, saving all 4. He paused. Special Forces Medical Sergeant qualification, which is the highest non-physician medical training in the United States military. Full stop. Her call sign in the unit was The Legend. We gave it to her because in 11 years and 5 deployments, she never lost a single person who reached her alive. He looked at Weston. Not one. The corridor had 21 people in it. I had counted when I arrived. Weston had the face of a man whose framework for the last 4 months had been revised in under 3 minutes, and the revision did not improve the framework's appearance. Behind Reyes, his team had come to attention. 6 men in the corridor, simultaneously, the sound of it precise and terminal. The gear, the posture, the silence that followed. And from room 6, where the curtain had been pushed aside by a hand wearing an Army Nurse Corps pin, Dolores Carver raised her right hand from her bed. 7 salutes. I stood straight. And then I raised my right hand, and I held it, and the corridor was quiet. Reyes looked at Weston one more time. "The nurse you called a cautionary tale," he said, "is the reason 2 of my men are going home with the number of limbs they arrived with. If there's something you'd like to add, I'm listening." Weston did not add anything. I went back to the wound care clinic, room 6 first. And then I sat on the stool beside her bed and unwrapped the bandage the way I always unwrap it. The wound looked good. Better than last week, the margins were clean. The tissue was deciding correctly. She watched my hands. 18D, she said. Again, not a question this time. Just confirmation of something she had already known. I said. I applied the new dressing. Now I'm wound care. She shook her head. Slowly, with the certainty of someone who has been in enough rooms to know the difference between what a person is and what a person is doing. You kept the watch on the right wrist, she said. I looked at my wrist. Habit, I said. No, she said. That's not habit. I smoothed the final tape edge and documented the assessment and stood up and stripped the gloves. In the break room, the coffee mug was still on the counter. $12. Corey had come back from the corridor, and she walked past it without picking it up, which meant the bet was over without anyone having won it, which seemed exactly right. I'm not the legend anymore. I filed that name away in 2021 with the deployment records and the meritorious service citations and the small photograph of an Oda that I keep in the same wallet as the watch card. What remained is the hands and the count and the specific way I read a wound that tells me what actually happened, rather than what the chart says happened. The mug stayed on the counter. Nobody collected. If this story stayed with you, if Junie's story is one you're going to be thinking about when you wake up tomorrow morning, hit that like button and share it with someone who needs to hear it tonight. Subscribe to this channel, because there are more stories where this one came from, and every one of them is true in the way that matters. And drop a comment below and tell me what city you're watching from. I want to see how far this one reaches.